saying. Today we'll be covering the Two-Midnight Rule compliance update for health law. Just a little housekeeping before we get started. We are using the GoToWebinar tool, and there is in the right-hand side you should see a set of tabs. There is a Handouts tab, and under that Handouts tab you should be able to download the Two-Midnight Rule compliance white paper that was previously published, and the slides from today's webinar are also up there called WATES Two-Midnight Rule. If you have trouble with either of those links, there is also a link to download the white paper in the chat file, but feel free to pull up in the questions tab and write questions in there. We will answer them as we go. Any technical questions I'll answer in line, but we'll hold and wait for questions, and Dan will take them at the end of the webinar. Let's see, I think that is all. You will all be on mute, and I think that's everything. I'm going to pass it over to Jenna.
Thank you, Mary. So welcome, everyone. I wanted to thank you for being with us today. As Mary already mentioned, this is our WATES, What Are the Experts Saying webinar, and today we're going to cover the Two-Midnight Rule. So it's a compliance update. Thanks for being here. And I am Jenna Ellis, and along with my colleague Dan Sotelo, there's our pictures up, we will be your moderators today. So you'll probably hear both of us, and any questions that you ask, Dan will handle at the end, and we'll give them to Tricia, and we can answer those during the time for questions. So again, thanks for being here. And I wanted to welcome Tricia. And she is our featured expert, Patricia Ruiz. She's a writer-analyst in, of course, the health law editorial team here at Wolters Kluwer. Tricia contributes to the Health Reform, WK Edge, the Health Law Daily, Medicare Explained, and, of course, the Wolters Kluwer Health Law blog. So thank you so much for being with us, Tricia.
Thank you.
Sure. So let's get right to it, and let's talk about where we're going to go today on this webinar. We're going to start just with this slide. It's just a quick overview. I'm going to start, of course, with the difference between inpatient and outpatient observation. How does that all work, and talk about how the Two-Midnight Rule was approached from a historical perspective. And then, of course, many of you know that we have received, as of almost a couple of days ago, a final rule for the Two-Midnight Rule. So we'll discuss that. And then we'll talk about where we see this rule fitting in as we look ahead, and any issues or compliance issues going forward with this final rule. Okay? So with that, let's start, Tricia, with observation versus inpatient. It seems like these issues are really at the crux of the need for this Two-Midnight Rule. So what is this distinction, I guess, and then why is it so important, just to begin with?
Definitely. So the difference between observation, which is an outpatient status, and inpatient, sounds like it would be clear-cut, but it's actually the confusion over this is the reason for the Two-Midnight Rule and why it's been kind of up in the air since 2013. So inpatient stays are paid under Medicare Part A, and generally for Part A inpatient, the Medicare pays one payment for all of the services provided to the beneficiary during that stay. So that would include the nursing staff, room and board, the use of the facilities, any drugs administered. And CMS determines that one payment based on the patient's diagnosis. So it doesn't really matter how long the stay is or what services are actually provided, because the payment is determined based on similar diagnoses. So it's kind of just a guess or an estimation on the part of CMS as to what kind of expenses the hospital would take in treating that patient. Outpatient stays, specifically observation stays, are paid under Part B. For Part B, hospitals will bill Medicare for each of the individual services that the beneficiary gets during that visit. So the more services the hospital gives, the greater the payment will be to them. So if you think of all the different things that could go into an inpatient Part A payment compared to a short outpatient stay. Medicare would pay considerably more for short inpatient stays than for observation stays.
And historically then, Tricia, I think there was a lot of inconsistency as to, is this observation, is this outpatient, all of that led to, even before 2013, a lot of inconsistencies. And we wanted to highlight one kind of real-world example, and it's an extreme example. You mentioned it in your white paper, but tell us about this couple, the Englers, and what they went through.
So the Englers kind of fall into this extreme example of the confusion over whether to admit someone or keep them in outpatient status. I'll start by saying historically, hospitals and physicians had discretion over when and whether to admit a patient or to keep them in observation. CMS gave guidance that the decision to admit can usually be made in less than 24 hours, and that decision would only take more than 48 hours in rare and exceptional circumstances. So basically what this says is that someone should be admitted if they've been in the hospital, let's say 48 hours, which is the high end of that. So with the Englers, Mr. Engler underwent a surgery and stayed in the hospital for 10 days, and he stayed in observation status. He was never actually admitted. So this is an extreme example, like I said, but there are many of these instances happening where people are in the hospital 2, 3, 4 days, and they're kept there in observation status when the guidance originally said 24 to 48 hours.
Okay. And I think that, in order to help hospitals or in order to kind of clarify when to admit, CMS came out with what we know as the 2 midnight rule, and that was in 2013 that we first kind of heard about this, right?
Yeah, leading up to the 2 midnight rule, so CMS was finding that people didn't have enough guidance in making their admission decisions. So in 2013, they created this 2 midnight rule, and it was solely a time-based criterion. And it was meant to help hospitals decide when to admit. But on the other hand, it was also meant to help recovery audit contractors who were responsible for reviewing the claims decide whether an inpatient admission was valid or not. So there are 2 parts to the 2 midnight rule. The first is more on the side of the RACs. Under the rule, there's a presumption that if a stay spans 2 midnights from admission, then it's automatically appropriate for inpatient admission. So RACs won't review these claims, they'll just approve them. And on the other hand, this is the part of the rule that kind of takes the hospital and the practitioner into consideration. RACs will consider inpatient admission to be appropriate based on the physician's expectation that the stay will last 2 midnights or longer. So that basically means the physician sees the patient when he first meets them, or he gets diagnosed, the patient gets diagnosed, decides then that he thinks that they will stay there 2 midnights or longer, then the inpatient admission is okay, even if for some reason it ends up just being 1 midnight or no midnights. So this rule was meant to be enforced for the 2014 fiscal year, but considering that it was a change and hospitals needed more education on it, they undertook the probe and educate process, where RACs would review these types of claims, but rather than making payment determinations based on that, they would educate the hospitals on their findings.
Okay. So if we kind of think of a timeline, this came out in 2013, but it actually, there was a delay, right, in enforcement.
Yeah, it actually, up until now, with the new final rule, the 2 midnight rule isn't being enforced until January 1st of 2016.
Okay. And so when we look at this, the 2013 2-midnight rule, one thing that I think was interesting upon read is that it seems to have this two-prong approach, where the first one is just strictly time, right? It's 2 midnights, and then the second one was, seemingly, I guess, this benchmark where a physician would have some input, but physicians, I think there were still a lot of objections, right, from the physician community because, I'm just summarizing, but they really said, look, it still is a time thing. It doesn't really take into account our judgment.
Right, because even with the 2-midnight benchmark, they're saying that the admission is appropriate based on the physician's expectation of the 2-midnight stay. It's not an expectation or a determination of the patient's medical necessity for the services. It really just has to do with a 2-midnight stay. So physicians and hospitals were kind of up in arms about this. They said that it was an arbitrary rule. It focused on time rather than medical necessity. They thought that it undermines their judgment. Physicians such as Ann Sheehy from the University of Wisconsin Hospital is one of the main people, or one of the major people rallying against the rule, who think that it's really just arbitrary.
Right, and I think a good quote is up here, that it's not really based on clinical need, but on time of day that the patient becomes ill, and of course, they have no control over that.
Exactly.
Right.
It kind of took it too far.
Right. You mentioned RACs, and let's talk about that for a second. Another criticism with this whole, really, I guess people have been critical historically, right, for with RACs, but RACs have been receiving even, I guess, more criticism, or they've become almost more of a problem with this new 2-midnight rule. How did that work? How did that work?
So the issue with RACs is that they are tasked with collecting overpayments and determining whether hospitals are billing correctly. So they actually receive contingency payments based on the amount of overpayments that they collect. So these payments can be between 9 and 12.5% of the overpayment. And as you can see from this American Hospital Association report, 74% of appealed decisions were reversed. So in the context of the 2-midnight rule, physicians kind of feel like, hospitals and physicians feel like there's a big incentive there for RACs to maximize their own profit based on what has become kind of an easy target based on the arbitrary 2-midnight benchmark.
Right, and again, yeah, we have another slide here with Ann Sheehy again talking about her testimony regarding those RACs programs, and again that they have this inducement to reduce payment.
Yeah, and then so the issue with specifically an example that Dr. Sheehy gave me was that some of their appeals of their claims appeals from RACs decisions would take up to like 500 days to resolve. So in that time, they're not seeing any payments. And then on appeal, if a RAC decision is overturned, they return the contingency, but there's no other penalty. So there's nothing really stopping them from trying to collect all that they can. And that was a major issue with hospitals and physicians.
Okay,
and putting
so then,
them in charge.
Right, that makes sense. So in response then to these physician groups, hospitals' objections, CMS refined, changed, whatever you want to say, and then recently came out with this new final rule. And I think that this was it was this month, right? You correct me if I'm wrong, and I believe that CMS really thinks that this new final rule responds to these objections.
Yeah, so this final rule, it did just come out, I believe, last week or the week before. it does respond to the concern of physicians that their professional judgment is kind of overlooked. So with this new final rule, the 2 midnight rule is not eliminated. It's still basically the same as it was, but it allows kind of more leeway for stays that would be shorter than 2 midnights. So the rule says that for stays that physicians expect to not cross 2 midnights, inpatient admission may still be payable under Part A, but only on a case-by-case basis and based on that physician's professional judgment. So then the physician has to thoroughly document the medical necessity for the admission in that patient's medical record, because obviously with the 2 midnight rule, any stays less than 2 midnights would be more heavily scrutinized.
Okay,
and,
so then, sorry, go ahead.
I was going to add that CMS also said in the rule that while it will allow some shorter admissions, they really expect an inpatient stay to last at least overnight. And like I said, they would be prioritized for review at that point.
Okay, so it seems like those, if there's a shorter stay, it could possibly be approved, but it needs to be the exception really and not the rule, right? And that if let's look, so this is the final rule that we have based on what they came out with a couple weeks ago. But if we look back at those, like the benchmark that we talked about with the 2013 rule, and, they said that they were giving, credibility to physicians, knowledge and judgment. This one really does change in that regard, right? Because those shorter stays, the old benchmark said, yes, it's the physician's judgment, but yes, it does still have to be the 2 midnights, and this gives a slightly more leeway, right?
Yeah, it does open it up for physicians to opt for shorter inpatient stays, but they didn't really dismantle the rule much. It is a lot of it is still the same as it was the first time, and while some physicians are happy with it, and actually a lot of them are glad that CMS is acknowledging what they've said, physicians still, I think, would prefer it to go back to the original standard of them just wholly using their professional judgment.
Okay. And then the last bullet here on this slide talks about the Quality Improvement Organizations, the QIOs is the acronym. And so can you tell us then about, what are the QIOs? Do they replace RACs, or are they working together? How do they fit in with each other?
So the inclusion of QIOs was meant to also address the concerns of RACs not being the best people for the job to review these claims. QIOs were created, I believe, by the ACA to help enhance the quality of care for patients. So rather than having RACs whose focus is payments and money, basically, reviewing these claims, they switched it to QIOs because they thought, with an eye on quality, that they were kind of better suited to review the claims in a less biased fashion. Because overall, while inpatient and outpatient distinction does play a part in payments for hospitals, it also affects the beneficiaries. For example, if a hospital chose not to admit somebody for an illness, there are certain services that aren't covered or that are considered inpatient only, and they wouldn't be able to benefit from those just because a hospital would be maybe too scared to admit them. So in this situation, it opens it up more.
All right, so if we think about January 2016 and this rule starts, the final rule starts to be enforced, are the RACs involved at all? Is it strictly QIO?
So starting this past October, QIOs took over the probe and educate process that RACs were in the process of. And starting in January, the QIOs will be conducting the initial reviews of the patient status to determine whether Part A payment is appropriate. RACs are still involved, but only to the extent where QIOs would refer a case to them in the case of a hospital or a provider who has high denial rates or is failing consistently to adhere to the 2 midnight rule, or who is failing to improve their performance after the QIO's attempt at education. And then on top of that, RACs are still involved as far as short inpatient claims, but not to review whether inpatient status was correct, but just their normal kind of was coding correct, was a particular service medically necessary, stuff like that.
Okay. So this is so new. Sorry, Dan, did you have a question?
I was just gonna add, just because there was a comment from one of the participants that just had asked to highlight that the QIOs were created in 1986. It says for the quality oversight aspect of care, and I think that reiterates what you're saying, Tricia, that now the QIOs are looking at this from more of a customer care perspective as opposed to kind of doing an audit of the billing. But in the cases where there's a lot of references, then that's where the RACs come in and do the audits. Does that sound like a fair assumption? Did I say that correctly?
Yeah, definitely. That sounds right. So it gives the providers an opportunity to work with someone who's kind of on their side or the side of the patient before having to pass them over to the RACs who are primarily focused, or their main purpose is the payment.
And then can I pose one of the questions while we're on this tab? I know we're about to, I want to jump ahead, but somebody else asked a really great question about, and I think you may have touched on this, but a question from one of the participants was about asking about how they would handle patients that expire prior to the 2 midnights. Could even be just a couple hours after they're admitted. That was a question. Yeah.
Oh, sorry, go ahead.
No, that was the question. Sorry.
Oh, okay. That situation would be covered even under the original 2 midnight rule, as long as the physician originally expected the stay to last 2 midnights. So in those kinds of situations, if the patient passed away or had to be transferred or discharged for another reason, because the physician originally expected the stay to be that long, then it would still qualify for inpatient.
Okay. All right,
in both situations, under this rule and the 2013 rule.
Right. Okay. Both times the 2 midnight rule was the final rule. It would qualify.
And before we move to looking ahead, can I ask one more question that a customer posed on somebody who's posed on the webinar?
Yeah, go ahead.
Sure.
One of the questions that just came in was how will the 2 midnight rule affect critical access hospitals? Is that one of the is there a difference that we know of, or?
I think I'm not aware of specifically any differences, but I can definitely follow up if necessary.
Okay.
All right, good. We can follow up with that information. Let's look ahead. We've been talking about kind of this new final rule and why it was created. And what are you following, Tricia, specifically with the new rule?
I think the main thing that I am keeping in mind is the 2 midnight rule is still in place, and the main change is going to be that case-by-case basis language that CMS used in the final rule. Since it's not actually being enforced yet, we have yet to see how the QIOs are going to interpret that language. So what that means is we don't really know to what extent physicians and hospitals are allowed to exercise their professional judgment. So, I mean, the best thing for physicians and hospitals to do is to always make sure to fully document the medical necessity for the admission, whether it's a stay lasting less than 2 midnights or more than 2 midnights. And then we'll just have to honestly wait and see what happens with the QIOs. Because the claims and appeals process takes so long, we probably won't anytime soon see any decisions, like administrative decisions or anything like that coming out. But what as far as current awareness I'm keeping an eye on is professional organizations such as the Society of Hospital Medicine, the American Hospital Association, the Center for Medicare Advocacy, and even MedPAC, to see once hospitals start working with these QIOs to see what kind of results are coming out of this new 2-midnight rule. And in the past, even before enforcement, these organizations have been really vocal about what the physicians want or what they think is working. So I'm definitely keeping an eye on that, and we'll be covering that in Health Law Daily and Health Reform WK Eds, definitely.
Okay. So when you just to summarize too, maybe the two, if there's an issue, I guess maybe there won't be, right? But if there are any issues, we're thinking maybe it will be with the kind of physician judgment, that portion of the new final rule, and then also with the QIOs and their reviews of the short inpatient stays. Those kind of seem, if there was an issue, that those might be the two areas, right?
Yes, definitely, because other than that, and other than physicians generally not liking having a time requirement put on their admission decisions, those are the two things that are up in the air, open for interpretation.
Okay. All right, Dan, do we have any other questions from the attendees?
Yeah, there was one question that was just asked to clarify that said if you could please clarify the delay until January 1, 2016. The question is, do facilities still need to follow this from 2013 through now, et cetera? Is that correct? Or just wanted to clarify the 2016 date, January 1.
Yes. I'm sorry. CMS is still advising hospitals to use the 2-midnight rule as guidance, and now that the updated rule has come out allowing more physician judgment, that's the one that hospitals should follow. And it really is also part of the education process to put those standards into place to make sure that when we hit enforcement, that they'll be able to take advantage of the payments that they're entitled to.
So that's the 2016 date is more the enforcement versus kind of the probe and educate phase.
Yes,
that still goes
yes, it's definitely, that's the, at least for now, and I don't see them moving it out again, but that is the definite enforcement date for the 2-midnight rule.
Okay. One other question that came in was just a question about do we know, do physicians have to explicitly write within the medical record that the patient is expected to have to be hospitalized for at least 2 midnights with the new?
Yes, they should actually, and with any medical record issue, they should always make it very clear, especially for 2 midnight, that they do have that 2 midnight expectation, because the time requirement is still in there. So I would even just say it explicitly 2 midnights in the record.
Okay. Let me look. There was one other question. I'm just scrolling up and down here. I'm sorry. Let me just look really quick. There was just a couple other questions. Does CMS consider overnight as 2 midnight or as less than 2 midnight?
It really is literally a standard based on the midnight. So if someone was admitted at 11:59 and then they were discharged after 2 literal midnights at like 12:01, then that would count for 2 midnights. It's not it's not really a flimsy rule, which I think is a lot of the reason for the pushback, because it really is arbitrary. 12 midnight is just a number that they picked, basically.
And conversely, if they were admitted at 12:02 a.m.,
Exactly.
Another question was just if we know yet what the criteria the QIOs might use to determine that a facility has a pattern of non-compliance that would require a referral to the RACs. Do we know what those criteria might be, or?
No, we really don't know yet. It's still up in the air.
Great. Just trying to jump in, trying to grab the questions that have I haven't looked at yet. Someone was just asking about what happened with the claim with a patient for the folks that we showed at the beginning of the webinar that were in observation for 10 days. Was that at that time? This was pre-2 midnight rule, but was that paid or denied? Was the question.
I actually don't recall, but it did. It ended up in litigation, I believe, and I don't really remember what happened.
If I remember the facts, I actually believe that they paid the part that had been denied. It was like $7,000, according to the story.
The anglers paid that.
So, yeah, the customers paid that. Or yeah,
right. Mm-hmm.
Is there a possibility that a claim for a patient's short stay case would be reviewed by a MAC and a QIO for medical necessity?
Unless the case was referred by the QIO to the RAC to determine whether there was medical necessity, RACs are keeping their hands off that determination. So RACs might still be looking at the same files for other issues, but not for medical necessity of the inpatient admission.
And I think you've already answered this, so you're probably just going to confirm yes. But when you said the 2 midnights, one question came in that I think it may have come in before you answered. Is 2 midnight meant to mean 24 hours? They are not the same, correct? I think you answered this, but with the
yeah, no, it's literal midnight. It must cross, the clock must cross midnight 2 times.
I'll just ask this question. I'm not sure we have material on it, but someone would just ask about the certification requirement. Is there any information on how that's changed, the certification requirement, or is that something we would need to follow up on?
I'm not sure if you mean by the medical record. I think that the requirements haven't changed other than the fact that the medical necessity has to be documented. But I'm not sure if that was the question exactly.
They mean the certification statement. Somebody has chatted.
Oh, then I'm not sure. We'd have to follow up.
Okay, we'll note that to follow up on. I think I've answered the questions. I'm sorry, I'm just scrolling through some we've already answered. Can you say it's changed? I think 24 hours. Let me scroll through. I think I apologize, folks, if I didn't get your question out there. We'll make sure to look at the list. I think that's all the ones that are unique that we haven't answered. I'll find. If not, we'll go through the list and we'll make sure we follow up. I apologize, folks. I don't think there's anything unique we haven't answered, but if we we'll go through the questions and we'll forward them on and make sure that we get back to you. Let me see here. We'll kind of answer the questions that we haven't in an email. Does that sound right, Jenna?
Yeah. Definitely.
I've downloaded the question log for you guys, so I can forward it to you, and you can follow up, and we can share with everyone as part of the webinar follow-up. Sorry.
Terrific.
Okay, so if we have any unanswered questions, we'll go ahead and do that then. All right, thank you, everyone. Tricia, thank you so much for your time and your expertise. And to our attendees, thank you very much for attending. We appreciate your time. If you have any additional questions, there is my email address right up on the screen. Of course, any training requests go to that second email. And we will also follow up with a really, really short survey link. And your responses to these surveys really help us come up with new topics that are important to you. So if you would just give us literally 2 minutes to answer just 5 questions, that would be great, and we would really thank you. So again, thank you, Tricia, our expert, Tricia Ruiz, and thanks to all the attendees for your time. Have a good day.